let's discuss the various investigations that we do. So, the first investigation or the initial investigation that you have to do. So, you saw a patient who is having the typical triad, and if the scenario asks you which is the first investigation or the initial investigation that you are going to do, it is the scan, that is the ultrasound, basically the transvaginal sonography. So, this transvaginal sonography gives us some information, that is, it helps us to rule out other causes, and if there is an endometrioma, we can see it through the ultrasound. Usually, small endometriotic deposits are not seen with the help of transvaginal sonography, and that's why it is not the investigation of choice. But the first line investigation is the transvaginal sonography. Basically, we can see the endometrioma. Along with that, we can rule out other differential diagnoses from this as well. What about MRI? So, MRI is not going to give us much detailed information rather than what we get from transvaginal sonography. We are not able to see or diagnose the small deposits that can be seen along with endometriosis. So, MRI can be used if we are suspecting a deep infiltrating endometriosis. But again, this does not come as an answer for any of your questions. So, the first line is the transvaginal sonography and the investigation of choice. The investigation of choice or the best investigation that can be done is laparoscopy. Best investigation is the laparoscopy. So, once you do a laparoscopy, basically you can see the small deposit, you can see an endometrioma, you can see the adhesions that is formed due to the increased inflammation. In case there is an infertility, we can, along with that, we can do a chromoperturbation also to see if the tubes are patent as well. So, it gives us a lot of information. So, along with that, we can treat in the same setting also. You can remove the adhesions, maybe remove the endometrioma as indicated. So, it helps us to diagnose as well as treat in the same setting. So, this is the investigation of choice. This is the best investigation, and even this is the gold standard investigation. So, if the answer provides you with laparoscopy along with histopathological diagnosis, HP, what it means is that once you see these lesions, you can take a biopsy from there and confirm that this indeed is endometriosis. That is laparoscopy and histopathological confirmation. If that is given, that is the gold standard. But most of the questions just give you laparoscopy. Even that can be chosen as the second best answer. So, investigation of choice or best investigation, laparoscopy. Gold standard is laparoscopy along with histopathological confirmation. Initial line of investigation is the ultrasound, preferably transvaginal sonography. Hope that is clear now. Now, let's have a look at few of the questions that is related to this topic. So, in this question, there is a 30-year-old female with infertility. Yes, that comes under one of our triad, infertility. She is having dysmenorrhea, dyspareunia. Alright, dysmenorrhea and dyspareunia. And on examination, we see that the uterus is retroverted with limited mobility and there is tenderness in the pouch of Douglas. So, what is the next step in the management? So, here basically she has undergone an examination only. We have done a clinical examination, but we have not done any investigation till now. So, the first line of investigation in her case is, yes, it is to perform a transvaginal sonography. Very easy, right? It is to perform a transvaginal sonography. If the same question gave me that the transvaginal sonography was done and it is normal now, everything is normal, but she is having all these symptoms. What is the next line of investigation? So, next I will go for to perform a laparoscopy. Will I do an HSG? No, HSG is not indicated in this. As I told you, MRI is not done. Now, let's look at the ultrasound features that can be seen in case of an endometrioma. So, in ultrasound, we can see that there is a homogeneous internal echo. This is one endometrioma. This is the other side ovary. Both can be seen together in this picture actually. And you can see that inside it is very homogeneous. That is, it is appearing the same throughout. There is a homogeneous appearance, and this is known as the ground glass appearance. Ground glass appearance. So, in endometrioma, you can see a ground glass appearance. Alright. Now, let's discuss a bit more about an endometrioma. So, endometrioma is considered as a true cyst. This is considered as a true cyst, and it usually involves both the ovaries. The bilateral ovaries are involved in this case. As you can see in this diagram, this is an endometrioma, and the endometrioma is also known as a chocolate cyst. It's also known as a chocolate cyst. So, what is the fluid that can be drained from endometrioma? Is it a clear fluid? No. The fluid is not a clear fluid, but a brown colored fluid. Brown colored fluid or a chocolate colored fluid is seen once we drain this endometrioma. Why is this happening? This is basically due to the collected blood, which later the hemosiderin deposits increases, and that gives a brown color. So, the color is chocolate colored or brown colored. We see that there are few cancers that can be implicated in case of an endometrioma. These cancers include clear cell cancer as well as endometrioid, ovarian cancer. These are the two cancers that are implicated. That is the clear cell carcinoma of the ovary and the endometrioid ovarian cancer. Now coming to the management. So, there is some problems that is associated with the removal of endometrioma. What happens is that while we are removing this endometrioma, basically we are going to remove some of the normal part of the ovary as well. And this will lead to decrease in the ovarian reserve of the woman. So basically, we have to be very judicious while going for a surgery, and the management option involves either an expectant management and the other is surgery. We will soon see what are the indications and what are the cutoffs while we go for a surgery in case of endometrioma. Alright. So, as I mentioned, the investigation of choice is laparoscopy, and let's have a look at the laparoscopic images that can be seen. We have already seen the laparoscopic image in case of an endometrioma. You can see the white ovary which is enlarged here. It is seen on both the sides, the bilateral endometrioma you have seen. Now, there are few other things, that is due to the small deposits. It need not be so big as an endometrioma always. Sometimes the changes are very subtle, and that is why it is difficult to diagnose as well. So, you can see the classic red flame-like lesions. Red flame lesions. You can see here that there is the red deposits or red flame-like lesions which is seen. Basically, it is due to the bleeding inside these deposits. Later, these deposits can turn into brown or black in color. This is known as gunpowder or powder burn appearance. Gunpowder or the powder burn appearance can be seen. This black deposits. Hope you can see and understand this. Now we have seen the powder burn appearance, red flame lesions, and sometimes there could be peritoneal defects that are seen. Peritoneal defects could be seen due to the endometriosis. Next. Now that we have seen the various laparoscopic images, it will be very easy for you to understand the various type of endometriotic lesions. There are the superficial endometriotic lesions, the deep infiltrating endometriosis, and the endometrioma. So, as we mentioned, the superficial lesions can be the red petechial dots or red flame lesions. The red flame lesions could be seen. There could be powder burn or gunpowder appearance. The deep infiltrating endometriosis is seen when it has gone below the level of peritoneum, and usually there is associated involvement of the uterosacrals, the bowel, bladder. So these patients usually have severe pain. So the pain in endometriosis is directly proportional to the depth of lesion. So the pain in deep infiltrating endometriosis is directly proportional to the depth of lesion. Next is the endometrioma. We have already seen in detail about the endometrioma as well. So these are the various types of endometriotic lesions. Now coming to the management options. So as for any gynecological disease, the management option includes the expectant management, the medical management, and the surgical management. When do we go for an expectant management? Sometimes we just find these endometriotic deposits while doing a laparoscopy, or we can find an endometrioma while doing an ultrasound, and the patient can be absolutely asymptomatic. So asymptomatic woman or a postmenopausal woman, we are not going to go for any further treatment. We will just monitor her. That is the expectant management. Coming to the medical and surgical management. So in the medical management, there are various drugs and treatment that is available. So we previously told that estrogen is a hormone that is implicated here, and there is bleeding that is happening cyclically, there is inflammation, there is pain. So all the drugs that is used to reduce these things can be used in the medical management. Let's see them one by one. This involves the NSAIDs. So NSAIDs basically decreases the inflammation, and it can be used as a first line treatment for mild cases of dysmenorrhea. In mild cases, you can give them NSAIDs. OCPs. So OCPs basically we can control the amount of bleeding that is happening. So every month while the cyclical bleeding happens, there is more blood that is collecting, that is causing pain, that is causing inflammation. So what can we do? We can give this OCP continuously for a period of at least 3 months. So OCPs are given continuously for a period of 3 months. Now we are controlling the bleeding, how it is happening. So if we are giving 3 monthly these OCPs, and she will have a maximum of just 4 cycles in a year. So just these 4 cycles means the amount of progression of endometriosis is also less. So OCP given continuously for a period of 3 months can be used. Again, we can use the progesterone. Progesterone basically stabilizes decidualization of these endometriotic deposits, and it decreases the bleeding in this. So progesterone can be again used. The various forms of progesterone like DMPA can be used, medroxyprogesterone, acetate, netta, all these can be used. Next is the aromatase inhibitor. So what is aromatase inhibitor? They are basically going to inhibit the enzyme aromatase so that the androgen is not converted to estrogen. So once this happens, again, the estrogen dependent these deposits are going to grow less. So aromatase inhibitors can be given. We would be dealing about each of the drug in detail regarding the side effects, the benefits, the dosage in a separate session. So now let's discuss how the GnRH is being useful here. So you might remember that the GnRH is going to stimulate the pituitary, and then the pituitary would be releasing the LH-FSH. This FSH is going to stimulate the ovary, and then the granulosa cells will produce estrogen. So how is GnRH actually helping in this situation? It should be detrimental, right? This estrogen will increase and the hormonal dependent endometriosis will just flare up. No, that's not the condition. What happens is that once we stimulate the hypothalamus with a lot of GnRH, once we start stimulating the pituitary with a lot of GnRH, there is excess of GnRH. What happens is that initially they will respond, but after a particular amount of time, all the receptors would be saturated and they are not going to respond anymore. Rather than hyperstimulating it, the pituitary is not going to produce any LH and FSH. That is why we are able to use this in case of an endometriosis. So as we are giving GnRH, it will cause a menopause-like state. There is decrease in LH, FSH, decrease in level of estrogen. So it can be used for endometriosis. But the side effect is that the woman can have these menopausal side effects as well. So once we are giving this for a long run, that is more than 6 months, the estrogen will be less. So as estrogen is less, the woman can have osteoporosis. She can have hot flushes. All the menopausal symptoms can be there for this woman. So in such cases, we usually give an add-back therapy. Add-back therapy means add-back therapy. So add-back therapy basically means that we are giving some agents along with GnRH so as to negotiate all these menopausal symptoms. The drug that is usually given is estrogen. You might be again thinking, why are we giving estrogen? Won't it deteriorate the condition? Actually, no. We are giving very low doses of estrogen, not unlike what is happening in the body. We are giving just low doses so as to negotiate these side effects. So, while you are giving GnRH for a long term, to prevent the long-term consequence of menopause, you have to choose estrogen along with it as well. Alright. Next is danazol. Danazol is again has androgenic action. Along with that, it has anti-estrogenic action, so that can be used. But androgens, many a times, they would cause androgenic side effects as well, which are irreversible. It can lead to virilization, clitoromegaly, all this in the woman. So, danazol is not commonly used. Another drug that is coming up and is being used now is the Dynogest. It's another newer preparation of progesterone. So, Dynogest can also be used. So, now let's discuss the various surgical treatment of endometriosis. So, basically the indications for a surgery includes a failed medical treatment, a failed medical management, presence of infertility in the woman, presence of infertility. In cases of severe dysmenorrhea. Alright. So, don't choose directly surgery in case of mild dysmenorrhea. Severe dysmenorrhea, which is not responding to initial line, then we can go for the surgical treatment. What are the various surgical options that are available? This includes the endometriotic cystectomy. We have discussed that in endometrioma, if the patient is asymptomatic, we can go for a conservative management. But in few cases, we will go for an endometriotic cystectomy. If the size of the endometriotic cyst is more than 4 cm, that is, it is equal to or greater than 5 cm. Some of the books give you just more than 4. That's because more than 4 means more than or equal to 5. It is same, right? More than 4. It is same as equal to 5 or more than 5. So, in that case, we can go for endometriotic cystectomy. So, the other surgeries involves either a fulgration. Fulgration basically means the ablation of the endometriotic deposits. Fulgration is the ablation of these endometriotic deposits. The adhesiolysis basically means the removal of the adhesions that is associated. We can go for another surgery, that is LUNA. LUNA is laparoscopic uterosacral nerve ablation. You understand that the pain which is seen here is severe. So, we can basically ablate the nerves that is causing the pain, so much pain. So, this procedure is known as laparoscopic uterosacral nerve ablation or LUNA. Hysterectomy. Do not choose hysterectomy as an initial resort. Hysterectomy is done as a final resort. And it is usually hysterectomy alone does not help. What is hysterectomy going to do? We are just going to remove the nidus or the presence of endometriotic deposits in the uterus. But we understand that the condition is not confined to the uterus, nor is the main culprit the uterus. The main culprit is the estrogen which is produced by the ovary. So, if we are going to go for a surgery, we will have to go for hysterectomy and bilateral salpingo-oophorectomy. And mind you, these women are very young. They are in their reproductive age groups. Usually, they are in 30 to 40s. So will we go for a hysterectomy and bilateral salpingo-oophorectomy? No, this is reserved as a final resort. So usually don't choose this as an option in your examination. Alright. So let's have a look at few of the examples here. So a 30-year-old female who's complaining of dysmenorrhea, dyspareunia, infertility. Now we are going to think of endometriosis. And yes, the ultrasound is showing a thin wall cyst with an echogenic fluid in the left ovary. Most likely she is having an endometrioma and it is 5 cm. And she wishes to conceive. What is the best treatment option? So here the answer is she is wishing to conceive. She has infertility, and for further treatment we can go for laparoscopic cystectomy in that case. Next, a woman who's having 2 children. Okay, her family is completed, yes, and she is having an left ovarian cyst of 3 cm, just 3 cm, and she does not want to conceive. What is the first line of management in this case? Will you go for a laparoscopic cystectomy? No, you won't. The size is less. Yes. Will you treat her with OCP? Let's keep that aside. Will you treat her with GnRH analog or progesterone? Alright. So her main complaint is dysmenorrhea and dyspareunia. As I told you, in mild cases, the first line is NSAIDs. Along with it, the COCs as well. If she is not responding, we can give her high dose of progesterone. If she is still not responding, we can go for GnRH analogs. So GnRH analogs come later in the line. Here even she does not want to conceive. So which is the better medical treatment? Is it progesterone? Is it OC pills? Here treat her with OC pills. How will you give the OC pills? You are going to give the pills continuously for a period of 3 months. If the same question gave you she is having just mild dysmenorrhea and she is aiming for a pregnancy, or she wants to conceive, mild dysmenorrhea and she wants to conceive, then you could have gone for the NSAIDs. Because once you give the pills, she is not going to conceive. So mild cases, she wants to conceive, go for NSAIDs. And if the case had given you that already all the treatments has been tried and she is willing for a medical treatment next, as the next resort only, go for GnRH analogs. Hope that's clear how you are going to manage various cases. So now let's have a look at this question. So she is a 40-year-old infertile woman, and yes, she has undergone a diagnostic laparoscopy, and there is presence of endometriotic deposit, there is chocolate cyst, and there is moderately dense adhesions that is seen for her. The treatment of choices. So here endometriotic cyst, we don't know the size of it. Here it is given the first option, total hysterectomy, bilateral salpingo-oophorectomy. Absolutely no, she is infertile. Even if she was fertile, it's not the first line. Danazol therapy, progesterone therapy, already you are doing a surgery, you have seen the deposits, you have seen the adhesions. Why would you just close her up and go back and give her medical treatment? Now is the time, you have seen the lesions, there is the problem, we can correct it then and there. That is why laparoscopy is a gold standard investigation. We are able to see, diagnose, confirm the diagnosis with histopathology and treat in the same setting as well. So now, rather than closing her up back, we are going to remove these deposits. Fulguration or ablation of the endometriotic deposits can be done. Along with that, if there is adhesions, we can remove the adhesions. If the endometriotic cyst is large, we can go for an endometriotic cystectomy. So that is the treatment. So be very careful while you are choosing or going for a cystectomy in case of an infertile woman. There are various problems that is associated with it. It is not just that you can see an endometriotic cyst and you will just remove it. Once you remove, you are going to definitely remove some of the follicles along with it. Some of the normal ovarian stroma is going to be removed along with it. So this will lead to the decrease in ovarian reserve. So be very careful while choosing for an endometriotic cystectomy. Don't go for a cystectomy if it is a small case of endometriotic cyst. Alright. Now coming to the other infertility treatment. So in this case, if first see what is the degree of endometriosis. If she is having, if the question tells you that she has mild endometriosis, in that case, we can give her treatment so as to induce the ovulation. So we would be giving her ovulation induction drugs in mild cases. In mild cases, go for ovulation induction drugs along with IUI. In moderate to severe cases. In moderate or severe cases, we will be choosing IVF. So in mild cases, it is just IUI. In moderate to severe cases, we can go for IVF. If there is endometrioma, size is more than 5 cm, we can go for a cystectomy in that case. Hope the topic of endometriosis is clear now. It's very important that you understand the theories that is there, the sites that are associated, the pathology or the pathogenesis of endometriosis, the clinical features, the investigation, and how you are going to manage each of these cases. Thank you.